you please stand?
Please sit down. Now, welcome everyone to the University of Edinburgh and to our historic anatomy lecture theatre, which dates back to 1888. My name's John Saville. I've been lucky enough to be Vice Principal and Head of the College of Medicine and Veterinary Medicine for nearly 10 years now. And I'd like to extend particular welcome to fellows, vice presidents and the president of the Royal College of Surgeons of Edinburgh, with whom the university has a very tight partnership. Now, the university is very proud of its teaching and research in clinical surgery. I'm delighted that at the moment we have no fewer than 5 full professors in general surgery and its sub-disciplines. We have a similar number of young academic surgeons heading towards professorships in prestigious postdoctoral clinician scientist fellowships, and a large number of young surgeons undertaking either Medical Research Council, clinical research training fellowships, or holding places on our prestigious Wellcome Trust clinical PhD scheme, the Edinburgh Clinical Academic Track. And I'm even more delighted that a good number of those young surgeons are women. And even though today's speaker is obviously a man, I'm hoping that the 13th Regius Chair of Clinical Surgery in the University of Edinburgh might well be a woman. Now, obviously, today's crop has an enormous amount to live up to. The history of academic surgery in Edinburgh is incredibly distinguished. Among those who've held chairs are some of the greatest names in British surgery, including Syme, Bruce and Woodruff. But preeminent among these clearly is Lord Lister, who was the 3rd Regius Chair of Clinical Surgery in the university, and as we'll hear, whose research literally saved millions upon millions of lives. Remarkable impact. So it's fitting that one of his successors, James Garden, should give a lecture in honour of Lister's 100th centenary. And although I can't spot him, I hope that one of James's predecessors, Sir Patrick Forrest, there's Patrick, is also here today. And indeed, James' immediate predecessor, Sir David Carter, who was also Chief Medical Officer in Scotland, will be attending the dinner this evening. Now, I'm sure you'll agree that today's speaker cuts something of an imposing figure. When James is training for one of his marathons, the streets of Newington, where we both live, literally shake as he passes. This clearly is in recognition of his enormous distinction. Not only is he the current holder of the Regius Chair, but he's Surgeon to the Queen in Scotland, and very recently won the university's very highest award for teaching excellence, the Chancellor's Award, presented to him by the Duke of Edinburgh in the Duke's last year of 59 as Chancellor of the University of Edinburgh. So with such a distinguished speaker, I'm confident that you won't mess up, James. And indeed, on a personal level, there's no one that I'd like close to my liver with a knife in their hand better than James Garden. So over to you, James.
Thank
you very much, Sir John, for these very kind words. As you and I know, I only was appointed to the Regius chair through a series of administrative errors, but I am obviously very grateful to the university for inviting me to deliver this public lecture. We have actually had an outstanding week. The Royal College of Surgeons have run a fantastic scientific meeting this week to commemorate or to mark Lister's, the 100th anniversary of Lister's death. And I hope that in the course of this lecture I'll be able to distill a little bit of that which I've picked up from the scientific programme and try and blend a little bit the history of Lister's contribution to surgery and reflect also on that which the College of Surgeons and the University of Edinburgh has contributed to surgery. I will be talking a little bit about history, but clearly in the time allowed, I'm not going to be able to go into this in detail, but I'd like to make two quick advertising pitches. The first is to let you know that there is an exhibition of Lister's work in the Royal College of Surgeons, in the College Museum, which has been put together by our curator, Chris Henry, and which is an outstanding opportunity to see a lot of the memorabilia relating to Lister under one roof. And I'm grateful to Sir John for his also helping to have the university place some of these items in the College Museum. And of course, here we are in a very historic anatomy lecture theatre. Lister would not have had the opportunity, clearly, of lecturing here, but there is also a historic anatomy collection here, and today the museum is open until 4 o'clock. If in fact you do get a little bit bored with the lecture, you have the opportunity of slipping out through the back door and you can go and see the anatomical specimens that are on show. And if you are not able to do that today, then you'll be pleased to know that the museum is open, I think, on the first Saturday of every month. So much for the advertising pitch. But can I now actually take you back a little bit in history? Many of you will probably only understand that Surgeons' Hall is a bus stop, which is not that far from Newington. But there is a very imposing building there, designed by William Playfair, the Royal College of Surgeons, an institution that has been in existence for over 500 years. I am going to try and indicate to you the ways in which the College of Surgeons and the University of Edinburgh have got together, but you must understand that they were competitor institutions, or had been competitor institutions for most of their existence. And in fact, I think it really was only in 2005 that there was a constructive discourse between the two institutions about how they might unite professional and academic excellence, and I will reflect a little bit on that. But maybe just take you a little bit back in history, firstly to the College of Surgeons. The college was founded on the 1st of July 1505. The seal of cause awarded it by to the Guild of Barbers and Surgeons of Edinburgh, awarded by the Town Council, is still in the college vaults. And it was actually a very far-seeking document in that what it set out was the rules, the regulations under which this guild or group of barber surgeons should exist. And as you can see, that basically the seal of cause indicated that no manner of person employ or use any points of the said crafts of surgery or barber craft within the borough unless they be worthy and expert in all the subjects belonging to the crafts. And you'll see that every man was to be made a freeman and master or maester amongst us. They had to be examined, approved, and they at that time clearly had to know everything about anatomy. Every man ought to know the nature and substance of everything with which he works, or else he is negligent. And despite what Sir John has said, you'll notice that in the seal of cause we're talking about he's. I might come back to that. One of the really far-reaching proposals was that the apprentices should actually both write and read. And I see a number of our trainees in the audience today, and I can confirm that they can both write and read. The college at that time did also manage to have a regulation that at least once a year a condemned man after death be made available to the college just to help with some anatomy dissection. I think that has lapsed a little bit in recent years. And one regulation which has clearly upset us greatly, and I know that our current president and past presidents have explored this avenue a little bit as well, is because it says that no person, man or woman, the woman does appear, within this borough may sell aquavit, whiskey, within the same borough, except the said maesters, brethren and freemen of the said crafts. And I really don't know quite why it is that the distilleries across Scotland have been allowed to produce all this whiskey without our having control or tax on that. The interaction between the college and the University of Edinburgh, as I say, has been one that over the years has not always been totally harmonious. But when one goes back through the history of the Regius Chair of Surgery in the University of Edinburgh, it is actually quite remarkable to see that of these now 9 deceased Regius Professors of Surgery, no less than 5 of these served as presidents of the Royal College of Surgeons of Edinburgh. I don't want to go through each one individually, but I can't help resist telling you the story about the first, James Russell, a man who had shocking red hair, or at least the wig was quite red, and tended to go around dressed very boldly. He petitioned King George III to try and raise some money for a chair of surgery in 1802. And not only did he succeed and help establish the Regius chair, but he also got appointed to that chair, the princely sum of £50 a year. I think it was actually, yes, it was £50 a year. Not a lot of money, perhaps nowadays, but at that time a reasonable princely sum. James Syme succeeded him, and interesting bit of history there in that James Syme's great colleague at that time in Edinburgh was Robert Liston. And when Russell decided to retire from the chair at the age of 75, he asked that a pension or payment of £300 a year be made by his successor. Robert Liston didn't like that idea at all. He was not going to make any contribution. He therefore withdrew from the application from the chair and moved down to London. James Syme thought that this was not too much of an investment. He bought the chair, and James Russell died the following year. So it was a very good investment by James Syme. I will now come and just touch on the third person along there, because that is Joseph Lister. I will tell you a little bit about how he came to Edinburgh, but just point out that because he married James Syme's daughter, there was clearly no question of him paying any money to James Syme for the Regius chair. And I'm not quite sure when this tradition lapsed, but I know that I don't get my £50 a year from the Crown, and I haven't paid my predecessor, Sir David Carter, any money to secure the chair. So Joseph Lister was a remarkable young man. He was an Essex man, born in Upton House, Plaistow, to parents who were Quakers. In April 1827, he went to a Quaker school in Tottenham, and then subsequently went to university, obtained a Bachelor of Arts at University College London. He was a very precocious child, a very bright child, and this may have come about because of his gifted parents. And his father, who had never had a university degree, Joseph Jackson Lister, was unusual because he was a a wine merchant, but was also a little bit of an engineer and designed the lens for the achromatic microscope, which very usefully gave young Joseph Lister access to some laboratory instruments at a very early age. He documented these, as you can see, beautifully in this little diary that he had here. He was a great artist, was great at documenting all these activities. And so by the time that Joseph Lister started medical school at University College in 1852, he had already published 2 scientific papers. And I think it therefore very likely that Joseph Lister was the first surgeon scientist. He started off as a scientist before moving into surgery. So he went to medical school, as I say, in 1850. He went to University College Medical School. He graduated MB in 1852 and also became a fellow of the Royal College of Surgeons of England in the same year. I would have to say that would not, President, happen in Edinburgh. We would expect the trainee to have undertaken a bit more training, to have shown aptitude in surgery before being awarded a fellowship. So I think already in the 19th century there was slight deviation in standards of the 2 colleges at that time. Lister decided to come to Edinburgh on the recommendation of one of his mentors in London because he had been told that the man to learn surgery from was Syme. And so he came to the Royal Infirmary, or to Edinburgh, where Syme practiced at the Royal Infirmary, which had been established in 1741 by the town provost, George Drummond. You have to understand that the Royal Infirmary at that time was not like our new modern Royal Infirmary down at Little France. The initial Royal Infirmary only had 72 beds. There was no water. The heating was by fires. The lighting was by lamps and candles. And I've been very kind here in putting down the fact that nursing standards were variable. Actually, if you read the literature, most of the time the nurses were under the influence of alcohol. So it wasn't necessarily a very safe place to be. But you can visit parts of the old surgical hospital round from the Royal College of Surgeons and obviously see a little bit of history there. But these buildings are still in the ownership of the University of Edinburgh. The Royal Infirmary, however, did actually try to establish some standards, and I couldn't resist looking at the statutes of the Royal Infirmary, which date back to 1778, and some really interesting guidelines on practice there. The first mention, I think, of multidisciplinary working, the fact that in difficult, doubtful, or dangerous cases, the surgeon in attendance is to call a consultation of the other surgeons. We do that still in the Royal Infirmary. Besides the assistance of the other surgeons, no operation of importance or which endangers the life of the patient should be undertaken without calling a consultation of the ordinary physicians. We know that they don't have much knowledge to bring to the discussion, but we do involve our physician colleagues also from time to time. This one I have put up for Sir John Savile because there's actually only one sentence about professors of medicine. They may have wards for both male and female clinical patients. They may regulate their attendance and times of lecturing so as shall be found most convenient and most conducive to the benefits of students. The University of Edinburgh still pays a lot of attention to ensuring that our students are prominent in our concerns. You'll see there's no mention about patients there, and I'm not quite sure whether professors of medicine ever bother to see patients. But what else was going on around that time? Well, I've just gone for 3 cartoons here to try and tell you a little bit about what went on. In the 1840s, there was no anesthesia. And therefore, for the greater part, there was no surgery. Surgeons did not operate unless they had to. That would therefore involve the patient having an amputation, usually because of osteomyelitis or tuberculosis or because of injury. Patients would normally die with an amputation. They would die without an amputation. And the results were not really very good. Robert Liston, who, as I told you, had been in Edinburgh, trained in Edinburgh, but of course is claimed as one of London's greats now, was responsible for undertaking the first operation under anaesthesia in 1846. Robert Liston was a skilled surgeon, as indeed was James Syme. Liston could undertake an amputation in 28 seconds. He also has a number of famous cases. The most famous case is the case that had a 300% mortality. He removed the leg, amputated the leg of the patient, who subsequently died from gangrene. Unfortunately, the assistant who was holding the patient down also had 3 fingers cut off and died from gangrene. And one of the audience, you'll be pleased I'm not going to do this here, but one of the audience who was watching the operation attentively got inadvertently caught up in the blade, which cut the tailcoat of this respected member of the community. That onlooker thought that he had sustained an injury to his groin, which he had not in fact, but the shock was so great that he collapsed to the ground and died. So surgeons in those days had a certain amount of bravado about them. You'll see that Liston is depicted there at the top right-hand corner as actually rolling his sleeves up and apparently with reasonably clean hands. But in those days, surgeons didn't really bother to wash their hands. Indeed, this tailcoat down here shows a number of stains there. It was a badge of honour for the surgeon to have lots of blood, pus on their coat. They would walk around town just so that they were recognised as being important men. And normally on the lapel of the coat were kept the needles and ligatures or ties that were used to deal with the blood vessels, which would inevitably be a problem with amputation. So Syme in Edinburgh lived through both these era, the pre-anaesthesia and the post-anaesthesia era. He was a very skilled surgeon, and clearly as Joseph Lister's master taught him well. Lister came up to Edinburgh as a resident house surgeon to James Syme at the Royal Infirmary. He sat a proper fellowship exam in Edinburgh a few years later. And very quickly moved from being a dresser to a clerk, lecturer and researcher with bases both in the Royal Infirmary and with activity in the College of Surgeons. He did a clever thing in 1856, which was to marry his mentor's daughter, and almost immediately was appointed assistant surgeon at the Royal Infirmary of Edinburgh. I'm sure there was no connection between the two. But as you'll see, he continued with his scientific work. He became a Fellow of the Royal Society, which was an appointment with which he was particularly pleased because his father had also been appointed a Fellow of the Royal Society because of his work on the achromatic microscope. Now, in those days, I said, surgeons didn't do much work. They didn't operate very much. And indeed, I think that, as you'll see, often the appointment that was made to a chair of surgery was followed by a period of inactivity. But what Lister did during this time when he was working with Syme was that he wrote up the cases that Syme undertook as the chief, as the surgeon, and he lectured a lot. And it was not uncommon for Lister to actually be standing at the door to make sure that those who came in had actually paid. You'll see the university on this occasion has been very magnanimous in not having you pay. Here on the bottom right cartoon is Lister, and although he was only the assistant surgeon to James Syme, he was known by his fellow surgeons or fellow trainees as the chief. He was the senior dresser, the senior assistant to James Syme, and had a very strong band of colleagues who revered him. I've indicated that during this early time in Edinburgh, he was a bit of a scientist. He continued his work on observation of circulation, inflammation, undertook some animal work, which was fairly fundamental to progressing the knowledge of surgical science at that time, and he published extensively during his time in Edinburgh. However, there was a slight aberration in his career pathway when the second Regius Professor of Surgery in Glasgow experienced a stroke and had to retire. And Lister did apply and was successful in his appointment to the post. Interestingly, the students at the University of Glasgow put together a petition to try and encourage him to move to Glasgow, 161 signatures. As you'll see, that doesn't actually always happen in Edinburgh. But he thought maybe he was going to something better, but he actually went to Glasgow Royal Infirmary, which at that time was a little bit dank, and although management invested in trying to improve in the conditions, still patients would come in dirty, unkempt. It was not uncommon to have 2 patients in a bed, and of course asepsis was not the rule of the day. And again, although he was appointed as the Regius Professor of Surgery in Glasgow, it wasn't until the following year that he received his appointment as a surgeon in Glasgow Royal Infirmary. So for 9 months, he lectured. And he devised his own curriculum. It was basically the research that he was doing that formed the basis of his lecture programme. Clearly, Glasgow at that time was a rather impoverished city. You'll see that the conditions in the old town were not very good. The mortality for the common operation that was undertaken at that time in Glasgow was recorded as somewhere between 36 and 53%. And indeed, after Lister's arrival, when he was carefully documenting outcomes before the antiseptic era of surgery, the mortality was 45% for those patients that underwent amputation. Edinburgh did seem to have a slightly higher mortality at that time. But I'm sure that I don't need to tell you that Lister's major contribution came about because following a discussion with the Professor of Chemistry at the University of Glasgow, who told him about the work that Pasteur had been undertaking on the germ theory. It was Lister who promoted this notion of attempting to prevent and stop the putrefaction of wounds by killing septic germs, which he actually believed were in the air and before they entered and directly infected the dead or damaged tissues. And just at this moment in time, just to show you the impact that had even in the Glasgow practice, is that you'll see whereas surgery was infrequently undertaken in the 3 main infirmary hospitals in Glasgow in 1855, it's remarkable, only 198 operations in total. But by 1870, up to 470, by 1885, elective surgery now was a possibility. And this was a case that changed it all. I've got a little sketch here of what apparently it looked like with Joseph Lister looking after a young 11-year-old boy called James Greenlees. I would have to point out that although when I came to Edinburgh in the 1970s, the nursing staff did wear these nice uniforms, these uniforms were not the norm in 1865. And even Lister at that time might not have looked quite so smart and clean. But this young lad, James Greenlees, was admitted to Glasgow Royal Infirmary with a compound fracture of the left leg. This had been caused by the wheel of an empty cart passing over his limb. There was a wound puncture, so there was dirt in the wound contaminating the deep tissues. And it was Lister's treatment of this particular wound by thorough application of undiluted carbolic acid to all parts of the wound, the cleansing of this wound and the application of dressings to this wound that enabled this young boy to walk out of hospital some 2.5 months later. These observations in 13 patients were published in the Lancet in March 1867. And I know that Sir John Savile will be very disappointed that surgeons do not frequently report in the Lancet, which is one of the high-impact surgical journals, medical journals. In the 21st century, it's very difficult for surgeons to get anything into the Lancet, but clearly in those days they were quite happy to publish the occasional case report or case series. But of the 13 patients that were managed in this way, all but 2 survived. And as part of this development, it wasn't just about the dressings. A lot of Lister's activities were directed towards trying to stop the contamination of the field around the wound. And he developed and designed a number of devices to have this spray keep the area around the wound clear. He continually tested himself. There were many designs of this carbolic spray. It was clearly one of the signature devices that was used to try and reduce the complications of infection at operation. And just to show that I have no ill feeling to colleagues in Aberdeen, I also just point out here a photograph which shows the great Sir Alexander Ogston, I think fourth from the left, looking over an operation here. You'll see that there are 4 assistants. On this occasion, they're actually looking rather than holding down the patient. I think an anaesthetic is being used here. And to the right, an assistant who's going to ensure that the carbolic spray keeps the operating field clear and clean. And of course, you see in Aberdeen, the surgeons there do roll their sleeves up when operating. Lister, in 1868, noted that the germ theory of putrefaction was the pole star which will guide the surgeon safely through what would otherwise be a navigation of hopeless difficulty. You must be able to see with your mental eye the septic ferments as distinctly as we see flies and other insects with the corporeal eye. And if you can, you'll be properly on your guard against them. Of course, the problem that Lister had at that time was what he was basically saying to his colleagues was that their dirty hands, their operative technique was causing all the problems, was causing all the death. And you can understand why it was that his views were not universally received with glee by surgical colleagues. And in fact, there was a lot of opposition to his theories. And the fact that he was always changing his approach to the management of the patient added fuel to the fire of criticism that came from colleagues who were rather just trying to suggest that Lister's theories were not well-founded. But at this time, he was also an innovative surgeon. Again, there's a beautiful sketch there on the left-hand side undertaken by Lister, who was trying to demonstrate an operation which he had described, which was to excise the infected joint of the wrist in the patient who had tuberculous arthropathy. He committed what some of his colleagues felt were heresy. I've put down here an X-ray. Clearly, no such thing as X-rays in these days, but he actually converted a closed wound of a fractured patella into an open wound by wiring the patella to try and speed the mobilization of the patient and the recovery of the patient, and succeeded in doing this without introducing infection or killing the patient. And he undertook one of the first drainages of a cerebral or brain abscess during his time in Glasgow. Now, we had one of our colleagues yesterday at the scientific meeting trying to remind us in Edinburgh that all of Lister's seminal work had been undertaken in Glasgow. She did not, however, say anything about the fact that all that Lister wanted to do when he was in Glasgow was to get out of the city. Because in 1864, he did apply for the second chair of surgery in Edinburgh, and for reasons I cannot understand, the wise fellow professors and dean at the time decided not to appoint Lister. Again, I think that might have been James Young Simpson and others who were rather against Lister. And Lister also applied for a chair down in London. Thankfully for Glasgow at that time, he got neither chair. And that was why Glasgow claims credit for Lister's discoveries of antiseptic surgery. However, Lister felt that he didn't get the support that was merited. And indeed, this seminal paper that was also published in The Lancet, which was really more of a public health statement about the cleanliness of operations, created a lot of controversy at the time. It was published just as he was leaving Glasgow. He had a little swipe at the hospital managers. I may add that my wards have remained during the 3 years without their annual cleaning, so he was not happy about the conditions in Glasgow. Syme, at that time, did decide to retire from the chair of surgery. There was another petition from the medical students of Edinburgh. I think they only managed to get 102 student signatures on this occasion. But Lister did come across to Edinburgh and was appointed as the Regius Professor of Clinical Surgery in 1869. Again, his consultant appointment to the Royal Infirmary only came a year later in 1870. And so during his early years in Edinburgh, was involved very much in teaching. But during that time, he was promoting the surgical antiseptic techniques. He was promoting a conservative approach to surgical disease. But during that time, he clearly had a huge impact on surgery. The tradition was that you would, as a surgeon, have a number of dressers or trainees with you. And during the 8 years of his appointment to the Regius Chair in Edinburgh, he had some 192 dressers who metastasized, disseminated off to other parts of the United Kingdom and the world to spread the antiseptic theory. He was a popular teacher. He did have a bit of a stammer, and there are comments in some texts that his delivery, his style of delivery was not always all that it could be. But his lectures were always welcomed, and during the time that he was in Edinburgh, he taught some 1,600 students. So he had a huge impact on medicine at that time. Also, just as another little aside, because of these developments, which he was recognized more internationally than nationally for, he was invited to the International Medical Congress in Philadelphia, which was convened to celebrate the anniversary of the American Declaration of Independence. He gave a 3-hour address on that day, which does seem rather long, but interestingly, in the audience, there was one Robert Wood Johnson, who is down here. And Robert Wood Johnson was a chemist and a dresser. And he went off and said to his brother, I think that we have something here that we could make a little bit of money out of. And what Lister had been doing also was looking at the issue of antiseptic techniques related to sutures. And one of the problems with the amputation was that if you were using something like a silk suture, that in itself could introduce infection. And it was Lister who promoted the notion that you could still use silk, or better still, use a catgut suture that had been soaked in carbolic acid that would reduce the risk of infection. And Robert Wood Johnson went off and with his brother set up Johnson & Johnson, which of course is now a huge conglomerate worldwide. Lister himself went on to experiment with these catgut ligatures, undertaking again some more animal experiments to establish their safety. When in Edinburgh, he also collaborated with one George Merson, who was based in the St John's Hill Manse in the Pleasance behind the college, who was again one of the founding figures of Ethicon, which is a Johnson & Johnson company based in the city. And just to give credit to Johnson & Johnson, here you'll see that they've done some innovative things. They've moved from these old types of sutures now to these more modern package sutures. I'm not sure that they were responsible for the fact that Listerine was given the name Listerine, but of course they are now responsible for the development of a number of devices which we use in a surgical practice. We still, even in this city, undertake collaborative research with Johnson & Johnson. Recently have been looking at techniques of hemostasis, stopping bleeding in patients undergoing liver surgery. So a useful collaboration between industry and surgery. And again, another journal that I'm trying to get an article published in at the present time is quite happy to accept an address to a catgut ligature. It sounds very Scottish, doesn't it? It's not quite a haggis, but this oration delivered to the Clinical Society of London was published in the British Medical Journal. And as you can see, the catgut ligature did exceed Lister's original hopes. He was clearly someone who took in every bit of information that was available to him. And it's quite remarkable, this little story here about how he saw an old fiddler amuse the patients in the Royal Infirmary of Edinburgh at Christmas time. The weather was wet, and he said that his fiddle would not work properly because the fiddle strings, which are of course catgut, are liable to seasoning and require it. And that was a very important fact because it served to explain the success that I had on my early experience with the catgut before I knew it all, the proper mode of preparing it. And it was Lister who added chromic acid to catgut to harden it and ensure that it lasted the pace, as it were, when the patient was having surgery. Edinburgh could not keep Joseph Lister here. He elected to move down to King's College Hospital in London, really because he was on a mission to try and convert those who still doubted his claims in relation to antiseptic surgery. In 1878, he was made the surgeon in ordinary to Queen Victoria. The fact that he also operated on Queen Victoria and lanced an abscess in her axilla or armpit might have had some influence on this award. Interesting, in 1887, he had abandoned the use of carbolic spray because by that time it was clear that it wasn't so much the bacteria in the air, it was more about the avoidance of introducing infection into the wound and keeping the operating field clean that was important. He retired in 1892 at the time of his wife's death. He developed strong affiliations to the Royal Society. In London in 1897 was made a peer, the first Baron Lister. He received the freedoms of the city of Edinburgh, London and Glasgow. He was one of the 12 original members of the Order of Merit and achieved the singular distinction of not only having secured the fellowship of the Royal College of Surgeons of Edinburgh by examination, but he is the only fellow of the college who has an honorary fellowship, which was awarded at the 400th anniversary of the College of Surgeons. He died in February 1912. He wished to be buried beside his wife, but the funeral service was held in Westminster Abbey and attended by royalty. Well, I can't really just stop at telling you about the history of Lister. What actually is his legacy? And I just want to pick on a couple of themes, if I may, and I apologise for the fact that I'm going to dwell a little bit upon experience in Edinburgh and perhaps in my own specialty of general surgery. But things have moved on as far as compound lower limb fracture are concerned. This unfortunate injury that this footballer has sustained here playing against Manchester United a number of years ago necessitated 28 operations to manage his compound fractured tibia and fibula. He didn't quite have an amputation, but he came very close to it. But clearly amputation is not what is undertaken now in relation to lower limb compound fractures. It's about external fixation, the management of the soft tissue injury, and the rehabilitation. And as a general surgeon, I can't possibly comment on how orthopedic surgeons manage that. We heard at our scientific meeting in the last couple of days about the challenge now posed by military injuries, war wounds, and the problems now that we have with improvised explosive devices causing terrible contamination and soft tissue injury at a number of sites. But what Lister was good at doing was auditing. You'll see here in these ward books from the Royal Infirmary in Edinburgh in 1870, very careful documentation of patients, admission, operation and outcome. In Edinburgh, there has been a very strong tradition of audit. James Learmonth here, as you'll see in a moment, was responsible for that. Pat Forrest, the younger version down here, when he was appointed to the chair of surgery in 1971, was also driven by audit and outcomes, specifically in relation to the management of breast cancer. My immediate predecessor, Sir David Carter, who was responsible for the acute services review in Scotland, and again promoting the importance of documenting good outcomes. And just to give you a flavour of what James Learmonth got up to in 1946, he started the tradition of the Saturday morning meeting. Nowadays, with European Working Time Directives, it's very difficult for us to get the team together on a Saturday morning. But at 9 a.m. sharp, the doors were closed. There was a presentation of the workload and the deaths and the complications, subjected to rigorous scrutiny and withering criticism. Of course, it was constructive withering criticism. In 1996, the Lothian Surgical Audit celebrated 50 years, an incredible achievement. It actually was the platform for the Scottish Audit of Surgical Mortality, which the college has been very strong in promoting, and I'm pleased that we have a Regius Professor of Surgery from Aberdeen, who is the current chair of SASM, sitting with us today, and is, I know, in the next couple of years going to take SASM on to a different level. But really, all of this is about discussing outcomes, whether they be good or bad, collating the data. And of course, it's been based on this that surgery has specialized. Fractured lower limbs are no longer the domain of general surgery. They're now in the domain of the orthopedic surgeon. But even in general surgery, the analysis of these outcome data were what drove specialization in vascular and breast surgery in Edinburgh. It ensured that we were able to deliver improved ICU, HDU facilities in hospitals in Edinburgh, and particularly in my own hospital in the Royal Infirmary. We were able to ensure dedicated wards and operating teams for emergency cases. It was one of the reasons why we were able to develop the Scottish Liver Transplant Programme in the Royal Infirmary in 1992. But even since then, there has been further specialisation, which has allowed us, particularly in Edinburgh, to provide an excellent training platform for some of the brightest surgical trainees in the country. I just wanted also to mention one professor of surgery who was not a Regius Professor of Surgery, but also who had a huge impact on Edinburgh surgery. Sir Michael Woodruff was the Professor of Systematic Surgery in Edinburgh. He undertook the first successful kidney transplant in October 1960. The press liked to latch on to this. The person who was put up in front of the press, I think, was one of the hospital managers, and we again just like to acknowledge the support we get from our hospital management team. You'll see that the comment was that I think the recipient has a sporting chance of getting away with it. I don't think this was any commentary on Professor Sir Michael Woodruff, but remarkable that in Lister's era the concern was about the patient dying from infection, and here with kidney transplantation, not only is one undertaking an elective operation, but one is then giving immunosuppressive therapy to the patient that can promote infection and cause severe complication and death. In 1992, we established the Scottish Liver Transplant Programme in the Royal Infirmary. Sir David Carter was very active behind that. Again, you'll see this time the hospital manager has moved to one side. The health minister, in fact, it was the Secretary for State for Scotland at that time, who got on the bed, which apparently we're not supposed to do nowadays because there's a risk of infection. We're also not supposed to wear a tie. We are also supposed to be bare below the elbow, but we couldn't tell the Secretary for State that. The kidney transplant programme, which Sir Michael Woodruff started, had moved to the Western General Hospital. It came back to the Royal Infirmary alongside the liver transplant programme in 1995, in fact not 1992. And just recently we celebrated what I think in Lister's day would have been seen as just heretical surgery, where we had undertaken the 1000th liver transplant in Scotland and the 1000th kidney transplant since the programme moved back to the Royal Infirmary in 1995. Actually, the The transplants were done in November and December, but we had to hold back the announcement just so that our paymasters could also link this up with the fact that they had just invested a bit more money in the transplant program. There's a theme emerging here. I can't tell you all of the outcomes, but the liver transplant program is in Edinburgh, as all nationally funded programs would do, have to report outcomes. I'm pleased to say that the outcomes in Edinburgh are as good as they are anywhere else in the country, and in fact, in many regards, are better. I have now withdrawn from involvement in the transplant program, but I have an outstanding group of colleagues who are continuing to produce excellent results. If you know the outcomes, then you can start driving service provision. And I'll tell you something here, that it's probably not our politicians who actually direct service provision. Just to show you an example of this, we're now in an era of minimal access surgery. And laparoscopic cholecystectomy has now been in existence for some 20 years. It's completely revolutionized the approach to the management of gallbladder surgery. And I apologize for the fact that I'm showing some data that emanate from colleagues in Glasgow, but these are Scottish data from the Information Services Division, which show that over the first 10 years of the institution of laparoscopic gallbladder surgery, some 80% of these procedures were being done using keyhole techniques. It increased the number of gallbladder operations being done because there was less patient resistance to the notion of having this surgery done. There was a reduction in post-operative stay. This procedure can now be undertaken on a day case basis, and this was associated with a reduction also in mortality. There are some problems, though, with these procedures. And I just put up this montage here to show you that sometimes the surgeon gets it wrong. And this is the operating field of a patient who was supposed to have had their gallbladder removed, which is over here. But unfortunately, you'll see that the surgeon who had undertaken what he thought was a very straightforward cholecystectomy has inadvertently removed the entire main bile duct, has exposed the portal vein, and has also doubly clipped and divided the main hepatic arterial blood supply to the right liver. This is a surgical accident. It was not intentional, but it happens. And maybe one of the reasons why there is a variation in outcome, despite a number of individuals focusing on the quality of the technique to avoid these complications. I just put up some data here which were published, in fact, from David Flum. David Flum is actually a surgeon who's visiting Edinburgh, visiting the College of Surgeons and our Scottish executive in May. He looked at the outcome of gallbladder surgery in the United States of America, and over an 8-year period looked out some 1.5 million gallbladder operations, which produced almost 8,000 bile duct injuries. It's not a nice complication to have. You'll see that if you look at 1-year survival, for those patients who do not sustain an injury to the bile duct, then there's still a few patients who die within the first year for one reason or another, but there's a 4-fold increased risk of death if the bile duct is injured. So it's not a good thing to happen to you if you're having elective gallbladder surgery. And this increased risk of death was associated not just with the bile duct injury, but increasing age and in fact, by an attempted repair by the same surgeon. Now, we don't document bile duct injury in Scotland. In fact, nobody documents bile duct injury in the United Kingdom. But you can look at surrogate markers of the quality of the surgery. And these are data that were published from England in 2005, 2006, looking at almost 50,000 gallbladder operations. And the remarkable thing about this is that the vast majority of these operations were undertaken as elective procedures, when in fact most patients who present with symptomatic gallstone disease present as an emergency. So it doesn't seem that many patients are actually being offered gallbladder surgery as an urgent procedure. Although laparoscopic surgery has taken over gallbladder surgery, there are still some 20% of patients undergoing open surgery. And if one actually looks at these two figures here, these are individual plots of hospitals in England and Wales. You'll see that when one actually looks at the day case rate, that there is tremendous disparity in the number of operations or patients being submitted to day case surgery. And if one actually looks at the outcome in terms of hospital stay, for open cholecystectomy, that is somewhere between 2 to 21 days across all of these hospitals. And if the operation is done as a laparoscopic procedure, is somewhere between 1 and 6 days. So clearly things aren't right in England, but it's what you would expect. But we have recently had cause to look at data in Scotland, and I'm grateful to Ewan Harrison, one of our lecturers, for putting in a tremendous power of work in looking at outcomes in this group of patients. Clearly, I would not have shared these data with you if the Royal Infirmary Edinburgh wasn't actually doing the most number of operations and performing the best. But if I actually just look at the year 2008 only, I just want to share with you some information which is in the public domain at the present time, but of which much has not been made, but which we will probably make more of as a profession during the course of this year. What is remarkable is that if you present to the Royal Infirmary Edinburgh for gallbladder surgery as an emergency, you are likely to have your gallbladder taken away. That is the standard of care. If you have a diseased gallbladder, it should be removed. And in fact, in the Royal Infirmary Edinburgh, more than half of the gallbladder operations that we undertaken are undertaken on an emergency basis. But if you look across the rest of Scotland, then you will see that the red bar varies considerably from hospital to hospital. There are some parts of Scotland where if you present with acute gallbladder disease, you will not get the standard of care. You will not have your gallbladder removed. You will be managed conservatively, and hopefully you will not have any further attacks of pain before you're readmitted to hospital for your elective surgery. But there's variation there that I think that we need to address, which is not related, I think, to the quality of the surgery being undertaken, but more to the way the service is provided. And in Edinburgh, we have reorganised our surgical services to put greater emphasis on the management of patients presenting with acute surgical problems. If you look at post-operative stay, which may be a surrogate marker for complication, if you look at readmission rate, then the Royal Infirmary Edinburgh is somewhere in the middle of the pack on both of these graphs. But given that we undertake more emergency gallbladder operations, it's perfectly reasonable to assume that that is because we're undertaking gallbladder surgery in more difficult patients. But why is it that across Scotland the duration of post-operative stay, the readmission rate differs so remarkably? There's one other issue that may require some consideration as well, and that is to actually look at individual surgical performance. And this bottom graph I put down there, just to point out to you, these are data from our own hospital in the Royal Infirmary Edinburgh, looking at the time that it takes for the surgeon to undertake the cholecystectomy. Over to the right-hand side, of course, is Joseph Liston, who undertakes an amputation in 28 seconds. This surgeon on the right-hand side is able to undertake a cholecystectomy in 35, 40 minutes on average, whereas over on the left-hand side, we have Joseph Lister, who was actually quite a slow, methodical surgeon. He takes 2 hours to undertake his gallbladder operation. These are interesting data. I'm not actually quite sure whether this means that the surgeon who's undertaking the long operation is worse than the surgeon who is able to complete the same operation in a shorter period of time. There are many variables there that come into play. We can look at surgical innovation. I'm just going to show you a little bit of brief movie clip here of this is what a laparoscopic cholecystectomy looks like. I hope nobody's going to faint, but because it's a long fall down to the bottom of the lecture theatre. But here on the left-hand side is the safe surgeon using instruments to carefully dissect out the tissues, to identify the anatomy carefully, and to do no harm whatsoever. Is this the good surgeon on the left-hand side? On the right-hand side, I put up for you the video of another surgeon. This is a slightly more challenging operation. Certainly he feels that it's a more difficult operation. The tissues are much more difficult to dissect out. The structure is a bit more difficult to define. He's not making quite the same progress as the surgeon on the left-hand side, but in fact the surgeon on the right-hand side undertakes the operation much more quickly than the surgeon on the left-hand side. The only difference between these two surgeons is that whereas the surgeon on the left-hand side is undertaking dissection of the duct that connects the gallbladder to the main bile duct, the surgeon on the right-hand side is actually dissecting out the main bile duct. And I'm not going to show you the picture where he puts the clips onto the bile duct and divides them, because it's a very painful experience for a surgeon to see. How, therefore, can we analyse this? And this is just to show you a little bit of interest. One of our current clinician scientists, Luke Davey, is looking particularly happy on the bottom left-hand picture because he's just submitted a grant application to study Roger Federer's swing. In fact, what we're looking to do in this particular project is not to analyse Roger Federer's tennis stroke, but to use this same technology in looking at gallbladder surgery and to perhaps understand, using some form of peer review, whether the surgeon who's undertaking the gallbladder operation is a safe surgeon, perhaps whether they need any support or remedial teaching. If we just talk a little bit about training, there is Lister with his fellow dressers, the chief. This is a little montage here to show you how things were in my day. We had no surgical simulation, and so we had to be innovative. You'll see that I am actually very skilled. You'll notice that we have an anaesthetist present. You'll see that we're not using ether or chloroform on this occasion, but I am trying very hard to do the So I'm not going to show any more. Thankfully, there are much brighter young people and colleagues who can make up for my surgical deficiencies. And one of the things that's been happening over the course of the Lister celebrations has been the Lister Surgical Skills Competition, which the College of Surgeons has organised. I think we've had over 1,000 medical students across the country enter into heats to undertake the sort of surgical procedures or simulated procedures that our trainees and even our consultant surgeons would be expected to undertake to demonstrate that they have acquired the necessary skills to undertake surgery properly. And this is actually just a little bit of movie from this morning. Our two grand vice presidents sitting there overseeing, as they always do, not actually scrubbing their hands here, but we have got some of our medical students who are actually here in the audience today being put through their paces to see who is the top surgical student in the United Kingdom. And but they are basically using the same sort of simulated devices that are available for our trainees and in the facilities that are available in the Royal College of Surgeons of Edinburgh. I want just to come back to the issue of Lister and surgical science, because there are some really quite stunning individuals out there in surgical science, particularly in Edinburgh at the present time. I don't want to embarrass them all, but just to point out, as Sir John has stated, that we currently have 5 clinician scientists in Edinburgh at the present time, and Mark Duxbury, who's undertaking his research work down at the Western General Hospital, is looking at areas of pancreatic cancer biology. Farah Din is working with Malcolm Dunlop down at the Western General Hospital and is looking at mechanisms of colorectal cancer chemoprevention. Luke Davies made another appearance here. He's looking at specific areas of hepatic ischemia, reperfusion injury, which will be important in terms of outcomes for patients undergoing liver surgery. Luke has difficulty going away for some reason or other. Stephen McNally, who's been supported by the Chief Scientist Office, has also been looking at preconditioning of the liver in liver surgery. He has actually now moved that basic scientific research to the bedside, currently undertaking studies on patients in the elective surgical setting, in the emergency setting, and also in the transplant setting. Here we have Damien Mole, who worked with one of our keynote speakers at the scientific meeting over the last 2 days, Ed Deach, in New Jersey. Damien is a disciple of Ed Deach and has been looking at mechanisms to medicines in an acute pancreatitis model, and we're hoping that the research work that he is doing and the substantial funding that he's now attracted is going to make a difference in the management of acute pancreatitis. Joseph Lister didn't have access to all of these computer animations, but here Ewan Harrison, one of our lecturers, who's currently funded by the Medical Research Council, is looking at organ damage, again in a transplant model, and collaborating with industry and hopefully keeping Sir John Saville and our Vice-Chancellor happy. We have extended our research out to other specialties. David Tolley, our president, will be pleased at the fact that we have an outstanding lecturer in urology at the present time. We're planting the seeds of future academic surgery in a number of different specialties, and Grant is doing excellent work looking at prognostic and predictive biomarkers in renal cancer, and has been, again, very successful in his grant funding there. I can't show the slides of all of our current research fellows, but you'll notice that unlike Joseph Lister, I'm blessed by the fact that I have 1 or 2 young female surgeons around me. They all seem to be very glamorous, which causes great difficulty for us. Andrew Robson, though not very glamorous, he's working on tumour-associated cells, stroma cells, looking at a very challenging area in bile duct cancer. Here, extending into vascular surgery, we've also got Jenny looking at MRI scanning, looking at some of the leading edge research in that area. And we have a number of these individuals not working in the Department of Surgery, but working under mentorship of other medical disciplines and benefiting from that guidance. As I've indicated, I'm blessed by the fact that I have a number of key individuals. I hadn't actually realized we had 5 professors of surgery, but I think I now realize, yes, with me as well, that is 5 professors of surgery, and a number of other bright young people coming up through the system as well. Joseph Lister was an educator. As I've indicated to you, his main income generation came through his lectures. The Royal College of Surgeons of Edinburgh and the University of Edinburgh have combined also in putting innovation into surgical training. The universities and the University of Edinburgh in particular tend to be concerned principally with producing medical graduates to go into training programs, and can provide opportunity for academic training, which is usually taken over a period of 2 or 3 years outside of the clinical training program. That lengthens the training for many of our surgical trainees, whereas it is almost certainly necessary for those wishing to pursue a career in academic surgery. It may not be necessary for all of those wishing to pursue an academic portfolio within their development as a health service surgeon. And it's for this reason that the University of Edinburgh and the Royal College of Surgeons have combined to provide an academic distance learning program which supports the trainee in the early years of surgical training as they move towards their membership of the Royal College of Surgeons, and then in the later years of surgical training to become a fellow of the Royal College of Surgeons. These distance learning programs don't require the student to appear at the lecture theatre. It's all undertaken online. Our MSc in Surgical Sciences is based upon the curriculum for the MRCS in years 1 and years 2. And there is an academic component in year 3 which allows them to acquire a master's degree as well as successfully negotiate their MRCS exam. This has been quite successful. We graduated our first group of students 2 years ago. This has been the fastest recruiting master's program, I think, in the history of the University of Edinburgh. I think there's a bit of income generation which has pleased the University of Edinburgh. It's actually allowed us to extend our tentacles out to some 40 different countries across the world. and as Sir John has said, has been recognised externally as having been not just innovative, but to be quality assured. Joseph Lister's legacy to surgery was immense. One thinks in terms of the pre-Lister era and the post-Lister era. He, as I indicated, had a large number of disciples. He was responsible for training and educating a number of key leaders in surgery in the years that followed his practice of surgery. The College of Surgeons, I think, are to be commended for the way in which they have worked with the University of Edinburgh in providing academic opportunity for surgical trainees throughout the United Kingdom and overseas. The College of Surgeons does extend its tentacles to some 90 different countries through, I think, a fellowship and membership of some 19 or 20,000 fellows. But we sometimes forget that the college is based in Edinburgh. I hope now, after this lecture, that you won't just look upon Surgeons' Hall as being a bus stop and understand the important contribution that it's making to surgery. Surgeons are clearly the most respected professionals in Britain. In this poll, they did not differentiate between physicians, general practitioners, and surgeons. I think if we had been taking the poll, the surgeons would have been polled at 100%. As it turns out, in this poll, nurses came first. So there has been some improvement since Listerian times. But it always pleases me to look at this poll and to see that our politicians struggle to get up the list. This has happened for a good number of years. The bankers have now fallen below the politicians, so they're battling for that second bottom spot. What can I say about the car salesman? So what is the legacy for the future then? Well, Mark Twain said that, the art of prophecy is very difficult, especially with respect to the future. So I will not try and prophesize what will happen in the future, but I think that the College of Surgeons, the University of Edinburgh, should take heart that we are in a good place. Edinburgh surgery is in a good place. So that Lister's legacy does remain strong. I think we've seen evidence that the College of Surgeons continues to demonstrate innovation in professional developments and setting standards. The University of Edinburgh specifically, I think, provides an excellent environment for academic surgical development, and both institutions at the end of the day have combined well to promote the highest standards of patient care. I thank you.
This production is brought to you by the University of Edinburgh.